in the 2 high intensity groups, which is the red and the purple, led to greater outcomes, in this case, changes in self-selected walking speed in a large cohort of individuals with chronic stroke. We've seen this in a bunch of different studies in chronic stroke. And when you look at spinal cord injury, stepping versus non-stepping activities, even when you're trying to do higher intensities but not walking activities, stepping seems to be better. And if you do this in high versus low intensity in both stroke and spinal cord injury, higher intensity seems to be better. And so this is consistent in stroke, spinal cord injury, and traumatic brain injury. When we think about doing high intensity, we are targeting higher cardiovascular responses, but it's really important that everyone understand like what we're actually trying to do. When you get those cardiovascular responses up, you're actually increasing muscle activity because the muscle needs the oxygen and the cardiovascular system delivers that. But the only reason the muscular activity is up is because the nervous system is increasing its drive to those working muscles. So yes, we're targeting heart rates, but that's a surrogate measure for what we really want, which is the nervous system to be driven really hard. And that's what we're really targeting, to kind of do a few things within the nervous system to enhance changes that we might see. So this schematic here, you have a short-term effect. So when you do specificity of walking, you are activating locomotor circuitry, and that's great. When you're pushing higher intensities, you're increasing neural activity, but in the brainstem, you're releasing 5-HT, which is 5-hydroxytryptamine, serotonin, and norepinephrine. And those modulators actually contribute to the activation and the modulation of locomotor circuits. They actually make it easier to walk. That increases power generation in the active muscles, which then elevates the cardiopulmonary demands. When you continue to activate that locomotor circuitry and you enhance those modulator release, serotonin and norepinephrine, you're strengthening locomotor circuits. That serotonin and norepinephrine is really important for that, which then really results in greater neuromuscular power over a long term and then increased cardiopulmonary capacity. So really driving that nervous system, which then drives the muscle and then increases the cardiovascular demands. This is a schematic on the left of the raphe nuclei where the serotonergic projections are. There's an ascending system, which is seen throughout the brain here, and then the descending system. With higher intensity trainings, those systems are activated to a greater extent. That serotonin descends down and drives the locomotor circuitry. So with high intensity training, you're activating your cortical circuits and reticular circuits, so reticular formation, which then drive those spinal circuits using glutamate and serotonin, which give you those short-term improvements. Serotonin also initiates growth factor synthesis. So just greater neural activity and the serotonin can lead to secretion of brain-derived neurotrophic factor and a bunch of other factors, which may lead to long-term locomotor gains. Right? So that's what we're really trying to do, which should enhance the plasticity of available nervous system structures to improve walking function. The problem is, as you all are aware, even though you get these gains in locomotor function, the impairments often persist. So what else is available? Hypoxia. Doesn't sound good, picture doesn't look good, but there's a real rationale for doing this. So when we think about hypoxia, a lot of people think about chronic intermittent hypoxia, which is sleep apnea type things, where you have a long duration, hours to days, several cycles a day, where you go in a hypoxic mode, where you lose oxygen delivery to tissues, and that goes for weeks to months. And the severe hypoxia is less than about 10% of the fractionated inspired oxygen content. Usually we're hovering around 21%, so you're dipping down to about 10% for a prolonged period of time. And that can lead to hypertension, memory and learning deficits, and metabolic syndrome. This is not what we're talking about. We're talking about acute intermittent hypoxia, which is very brief, a few cycles a day. You do it in a few minutes to hours, and it's mild hypoxia where it's a little bit greater than 10 or hovering around 10 for FiO2. And that leads to a positive adaptation potentially. And they call it here therapeutic sport preconditioning, but we're actually trying to activate the nervous system. I'll talk about that in a sec. So the original studies of this acute intermittent hypoxia were done in a hemisected spinal cord injury model in a rat. So what you're seeing here is the brainstem respiratory generators in just a schematic. And what they did to the rats is they gave a C2 hemisection. And you know that the diaphragm is innervated by C3, 4, 5. And that's where the phrenic motor pools, which innervate the diaphragm, are located. When you have that hemisection, you're driving one side of the phrenic motor pool from those brainstem respiratory generators, which increases the drive to the phrenic nerve, the diaphragm. But then on the other side, you don't have that drive as much. So you get only kind of a partial ventilatory response, because really you're not driving half of the chronic motor pool in this situation. When they look at this spontaneously, what they tend to find is that the phrenic nerve activity on the side that was actually had the hemisection, so ipsilateral phrenic nerve activity, that tends to come along gradually when you just let the animal kind of work its way through the actual injury. They found this cross-synaptic pathway that is there, but just is more expressed because of the demands of the task to drive that ipsilateral phrenic nerve. So that cross-synaptic pathway becomes enhanced in its plasticity, and then the unilateral brainstem generator can drive both of the phrenic motor pools. One of the techniques they try, like how do we actually enhance that drive to that ipsilateral phrenic motor pool with some kind of intervention to improve respiration. So what they did, and this is work by Gordon Mitchell, is they would do 3 bouts of hypoxia. So here, remember, normal oxygen's 21%. So they keep them at about 50% of fractional O2, and then they drop to about 11% O2 for 3 5-minute bouts, right? And so that when you look at the phrenic neurogram, they're recording from the nerves of the diaphragm, and this is the integrated phrenic neurogram where it essentially just flipped and smoothed out. During those actual bouts, that activity increases, and then 60 minutes after those bouts, they found that the integrated phrenic neurogram was actually improved, like greater, even without the hypoxia on. So what's happening during that time? Why did the hypoxia elicit what seems to be this long-term ventilatory increase? And so what you're seeing here is those phrenic neurograms all kind of compressed together, and they're integrated, they're not smoothed over. So this indicates the 3 bouts of the intermittent hypoxia when you're driving the respiratory generator to a greater extent because it is hypoxic. And then you go back to baseline. Over time, you see that gradual increase in the electrical activity from the nerve. So the phrenic motor pool of the injured side, the ipsilateral side, is driven harder, which is this signal over here. These are the same. They've called this long-term facilitation, and that can improve ventilation without hypoxia there anymore. During hypoxia, you definitely increase that drive, but after it's gone, then ventilation's improved. So what's happening during that time? So the hypoxic exposure signals the carotid bodies to increase stimulation to the brainstem respiratory generators. So you're getting these carotid bodies, they're sensing low oxygen, they're going to go back to the brainstem and drive that brainstem activity harder. That's going to increase the drive to the diaphragm with glutamate, but it also stimulates that reticular formation. Just think about this for a sec. You're taking an animal that can't breathe well, and then you're giving it less oxygen. You're stressing it out. And that stressor causes that secretion of serotonin, which then modulates the drive to that phrenic motor pool. That results in BDNF release. And BDNF release is critical for that long-term facilitation that we saw afterwards. So in a paper by Tracy Baker Herman, this is just a couple figures. If you block protein synthesis for BDNF, you don't have that long-term facilitation. If you block the receptors for BDNF, you don't have that facilitation. So this facilitation is being caused by the BDNF. And if you block serotonin receptors, you also don't get this. So the serotonin drives the system harder, you get the BDNF, and that is the long-term facilitation. All right. So serotonin is not localized to the cervical spinal circuitry. We talked about locomotor activity. And then a study that extended upon what happens to non-ventilatory outcomes, what happens to motor outcomes. So Gillian Muir, in the laboratory of Gillian Muir's Levette Barr in 2012, they gave a rat a spinal hemisection, and they also did the hypoxia. And then they looked at the animal and its ability to ladder walk. So this is a rat going over this obstacle, and here's the actual rungs that the animal has to actually navigate. And they look at the correct four-limb steps, and they find that with repeated treatments over 7 days of this acute intermittent hypoxia and then training the rat to do this kind of ladder task, the black indicates that the animals that got the actual intermittent hypoxia, they did much better at the task versus the animals that did not. And that was long-term, even after the hypoxia is done, 14 and 28 days after the initiation. So potentially, intermittent hypoxia could improve motor outcomes as well as ventilation outcomes. So they extended this in humans. And the initial work was done in Chicago by Randy Trumbauer and colleagues. And what he did is he did 30 minutes of hypoxia, 60 seconds on, 60 seconds off, dropping down to about 8 to 9% of O2. And he saw a 20% increase in maximal ankle strength. I apologize, this is 2012, not 2014. So wrong year there. When they subsequently did training in another study, a couple of studies, so this is Heather Hayes, and then a group down in, I believe, Brazil did this. They did a baseline testing and then they did acute intermittent hypoxia for 5 days. And they did that 30 seconds on, 30 seconds off, had them walk over ground for 30 minutes afterwards, and then did post-training. They found that the group that did the acute intermittent hypoxia had greater benefits in 6-minute walk. So this is the changes at day 1. The hypoxia is in white. The control group is in black. And then day 5, there's a larger difference. The follow-up on 1 week later, there's a larger difference, and then maintained to some extent at the 2-week follow-up. So just this little amount of training with the hypoxia seemed to improve motor outcomes when it's coupled with walking. Now they tried to go fast over ground walking, but they didn't measure heart rate, and there's no attempts to do high intensity training. So this is not really doing high intensity training by any indication that we could see in these papers. Further questions. So most of the data was in patients with spinal cord injury. There are 2 papers in models of MS and Alzheimer's that suggest that hypoxia may have a benefit. And the motor effects in individuals with stroke was completely unknown until we tried it. But the idea that I had was, well, if it works in spinal cord and the nervous system is kind of the same, yes, different pathways are damaged, why wouldn't it work in stroke? And so the idea was, let's give it a shot. The problem that we had was that intermittent hypoxia hadn't been combined with high intensity training, and you might have similar potential serotonin and BDNF mechanisms. So the idea was, is this going to be additive, or is they just going to cancel each other out? And you don't even need to do the hypoxia as long as you do high intensity training. Because again, the high intensity training is utilizing those serotonergic pathways to get BDNF synthesis to elicit short and long-term improvements. And then the acute intermittent hypoxia theoretically works through the same mechanism. So do you get better benefits when you add this acute intermittent hypoxia with the training? Okay, so in doing the study, we did a double-blind randomized clinical trial. It was also a crossover design. So what I didn't mention in those other human studies is that all those studies were a crossover. They would do the training, wait a couple of weeks after the training, and then give the group the other intervention, whatever they got, right? So we did that as well, just to see what's the potential effects of this intervention with high intensity training in this population that has never really been tested before. It was double blind, meaning that the therapists treating the patients were mostly blinded. The assessors were blinded, but the patients were blinded. So we're actually manipulating the oxygen. They're wearing a mask, and theoretically, they should not know which one they actually are being exposed to. Some individuals can feel that there's some kind of effect, but it's usually pretty mild. Again, randomized design that we utilize with most of our studies. So we assessed 55 people. We were able to get 35 that were enrolled. We had 7 dropout, but 28 finished both arms. So 20 in the hypoxia group, 15 in the normoxia group. They finished testing. We lost a couple people, 1 in each group, or a few in each group. The crossover again, we lost a couple more, and then we analyzed both on protocol, whoever finished the entire study, and intent to treat. Whatever group they were randomized to, we took their data. We used something called a regression imputation, which I can talk about. It's just minor stat stuff. The primary analysis was on protocol. Does this high intensity training actually work better? And the secondary analysis was both intent to treat and then the first arm only. We just forgot the crossover in the secondary analysis. We're just going to focus on who got better on the first bout when they got randomized to either hypoxia or normoxia. Okay, so this is the schematic on the top right. So individuals would do 5 weeks, up to 15 sessions of acute intermittent hypoxia plus high intensity training, or normoxia plus training. Again, participants were blinded. So individuals were randomized. So they were assessed before the randomization. They were randomized. Again, 5 weeks of either intervention. They were retested. We waited at least a month, and then we ran it again with normoxia and hypoxia switched. Again, the researchers, like us manipulating the oxygen, did know the intervention. The therapists training mostly did not know, but sometimes some of us had to fill in, but the assessors were blinded and the patients were blinded. The schematic looked like this. Here's your hypoxic chamber. And here's a tube with the patient. This is Abby, the therapist, just for picture purposes, wearing the mask. We've got a SpO2 sensor on the forehead. We've got a monitor measuring how much of the fractional inspired oxygen is actually being inhaled. Here's the protocol. 30 minutes of going back and forth from about 21% to about 9%. And the desire was to achieve oxygen partial pressure of about 82% of normal. So 100% would be normal. The bouts were 60 to 90 seconds on and about 30 to 60 seconds off. So 2 minutes for one whole bout. And the reason why it was variable is we're trying to get down to about 82% in these individuals. After they're done with the 30 minutes, we did high intensity training, focus on stepping practice for 60 minutes, and that would be 40 minutes of a session of trying to get at least 40 minutes of a session to walking, no more than that within that hour of time. If we couldn't get 40 minutes, we stopped it, but we always try to get those at least 40 minutes through the next hour. All right, high intensity training. There's a paradigm to this. It's not just walking forward on a treadmill, although you'll see that here. Here's an individual who's about half of normal walking speed on his first day of treadmill training. And this is just a video not from the study. We'll do overground, we'll do stair climbing here. We're working on him pulling the individuals forward with the light gait, really using his his right non-paretic limb, walking up on an incline, trying to get those heart rates up. There's a heart rate sensor on his forehead. We're targeting at least 70% heart rate reserve. This is his first shot at running. And this is his last shot at running. So really trying to get to the higher intensities with these individuals as fast as we can and doing different task demands. The stepping tasks were both treadmill, doing forward walking and variable, and then overground, stairs, and overground. We focus on specific biomechanical subcomponents, so stance, swing, propulsion, postural stability, things that get someone from point A to point B. I'm not going to go into the details of that, but I'm happy to talk about those details. It's not just walking. Here's an individual who's lower level, more impairments. And here we'll do forward walking for a bit. We'll do backwards walking without holding on. So some skilled activities, trying to step over obstacles. Not worried too much about her success, as long as she does have some successes, but really just kind of keeping the walking going to try to get those heart rates elevated. Going up the stairs, going up the Stairmaster with a harness on it, really trying to push the intensity, and you see the heart rates down below. Here she's over ground with an 8-pound weight, and then now she's going to try to negotiate a balance beam. I get that no one walks on a balance beam in real world, but if you can do this, then the nice level surfaces is pretty easy. All right, so assessments were done prior to and following each arm. So before and after each one of these blocks, waiting a month, and then before and after again. The primary outcomes were, because we had no idea this is going to work, we're going to be these 4 outcomes: self-selected walking speed, fastest possible speed, 6-minute walk, and then peak treadmill speed during a graded exercise testing where we start at a very slow speed and increase the speed until the person just can't go anymore. Alpha value was 0.0125 because you're correcting for Bonferroni. Secondary outcomes were gait symmetry, so single limb stance, Berg, sit to stand, classic clinical measures. All right. The analysis was a three-way ANOVA, and so that is just three main factors. The main factors that were repeated were baseline and post-training. Everyone did the crossover, so we did baseline and post-testing twice, so they each of them had that twice. The training arm, where they got hypoxia or normoxia, and in the primary analysis, everyone got all of those. And then the order, whether they got hypoxia first or hypoxia second, and then that wasn't repeated. The secondary analysis omitted the crossover. So we did the analysis of the first group as well. The crossover design with HIT may result in smaller effects because you expect that the effects of the training initially wouldn't completely wash out in a month, but we only waited for a month because we wanted to get the study done in some reasonable amount of time. And then we looked at adverse events. So serotonin, in the form of selective serotonin reuptake inhibitors, increases spasticity definitively. It absolutely happens. So we looked for increases in spasticity and any other adverse events that might actually present itself during the study. All right. Sorry, this. So participants in training. So participants were not different between the hypoxia first or second at the start of the first assessment for either one. These are the training characteristics, the bouts of hypoxia or normoxia, and then during the high intensity training session. So for training, hypoxia and normoxia were different between the groups. And here, that's what I'm showing here. So the fractional inspired O2 percentage was 21% in normoxia, as you would expect, and we got down to 8.3 on average with a hypoxia group. The saturated or percentage oxygen saturation was 99% in normoxia, down to 82 on average, and the heart rate was elevated slightly in the hypoxic conditions. If you look at the high intensity training variables, they were not different. Individuals got the same duration per session, 31 minutes. We looked at heart rate reserve, calculated using both predicted heart rate max, so age predicted, or their observed max, what's their peak heart rate during treadmill training. And we're getting to about 65 to 66. We're aiming to get 70, but it's tough in some individuals because of their impairment or certain medications. But that averaged about 100% of what their maximum heart rate was during a treadmill test. Ratings of perceived exertion were a 16, and so a 15 is hard, a 17 is very hard, so right in the middle of that, not different between groups. We counted steps throughout each session. Little monitors were on their legs, step watches, and that was not different. And then steps per minute, the stepping rate was not different between groups. All right, so when you look at outcomes, this was the interesting part. So if you look at the hypoxia, you see a pretty big bump in self-selected walking speed from 0.51 to 0.64, so 0.13 meters a second, and you only see a 0.05. That difference was significant, and there was no effective order, meaning it didn't matter if you got hypoxia first or second, hypoxia seemed to do better. Same thing with fastest speeds, a pretty big bump, about 0.16 with hypoxia, and only about 0.06 with normoxia. That again was significant between groups and no order effects. Didn't matter if you got it first or second. And if you analyze the first training only, you revealed similar significant effects. So the hypoxia seemed to work where they did the crossover, or whoever got the hypoxia first only versus normoxia, that seemed to be better. Peak treadmill speed actually got significantly better as well. That was about 0.22 to about a 0.12. Technically, no order effects because that's not significant, but there was a time and training interaction. 6-minute walk was not significantly different. And that's important somewhat because when you do all these high intensity training studies, usually the primary outcome you get that is significant is going to be 6-minute walk. So there was no difference between the groups in that measure. All right, if you look at the chart, so what you're looking here are the 4 primary outcomes of self-selected, fastest speed, 6-minute walk, and peak treadmill speed. And if you look at the triangles, that's going to be the group that got normoxia and high intensity first, and the dotted line is when they get the normoxia, and then those triangles switch to the solid line, and they got the hypoxia second. The squares are going to be hypoxia plus high intensity first, and then they'll switch to the dotted line in the second half. What you probably want to look at are the slopes of these lines. So the slope, particularly in the first bout of training, the slopes of self-selected, fastest, and treadmill seem to be higher for the hypoxia versus normoxia. And then you average all the data together, the trend is that hypoxia was better throughout. 6-minute walk, those slopes aren't too different, particularly in the first part, and maybe favoring the hypoxia a little bit in the second part, but again, not significantly different. All right, one thing that's important, when we do training with high intensity training, we typically see that an individual improves, let's just focus on the triangles, improves their walking and then maintains that and then goes to the walking again. Here's treadmill. They improve their treadmill speed a little bit, but what happens that these individuals didn't maintain? There was a drop off from after hypoxia, waiting a month, and then testing again. So that drop off we never see. So big red flag, like there's a caveat here. This might work, but this is a finding that we didn't actually anticipate and never see before. But that drop off may allow that group in the second part to actually improve to a greater extent in the second training epoch. Nonetheless, the first training period was significant between the groups. Other assessments. Single limb stance time was significantly different between the groups in both self-selected and fastest. So symmetry seemed to be improved with hypoxia. Also a bit of a flag there. That symmetry seems to improve with faster walking speed. So that may be just a caveat of that. Then Berg and 5-time sit-to-stand, other clinical measures were not significantly different between groups. Adverse events. There are no reports of increased spasticity, although temporary increase in spasticity is common with high intensity, but it was never observed or reported with acute intermittent hypoxia. So the hypothesis is that high intensity training elicits that brainstem activity, serotonin secretion, and that drives that short-term increases in spasticity with the high intensity. And if hypoxia was actually working through serotonergic mechanisms and the individual was that stressed, you might see that increase in spasticity, but we didn't see any of that. There was one serious adverse event. One individual had complained of shortness of breath after her very first bout of hypoxia. So she had done the high intensity normoxia, waited a month. We started up with the next bout of acute intermittent hypoxia, and after just the hypoxia, on the first couple minutes on the treadmill, she started getting shortness of breath and dizziness. We got her down, sitting on the treadmill, and we got the EKG to play. She had supraventricular tachycardia, which had never been reported in any study with hypoxia in humans. No reports in the literature. The IRB agreed that it was not related to the intervention. Discussion. So intermittent hypoxia plus high intensity tended to improve gait speeds over short distance and peak treadmill speeds, and some gait symmetry over normoxia plus high intensity. And that's consistent with the SCI studies in humans that we had seen before. There were no differences in training variables that suggested that that intermittent hypoxia did not modulate immediate changes in walkability. It only probably elicited long-term differences, which we saw statistically. So there may be a potential additive effect. We're just not quite sure yet. It's just one study. That drop off in outcomes is something we think that needs further investigation. We're not sure why that group dropped off, but it's important to keep on investigating and see how consistent these findings are. Again, no report of spasticity. So the question is this actually working through serotonergic mechanisms? Because serotonin absolutely increases spasticity in individuals with stroke. We just didn't see that. And then lastly, supraventricular tachycardia. Yes, it was only one event, but there is reports in the literature about hypoxic events in those with sleep apnea that they actually can develop supraventricular tachycardia when they become hypoxic during sleep. So again, something to watch for when we're testing these individuals. Other factors such as how much hypoxia they got exposed to during the intermittent hypoxia, different types of drugs that can influence the changes you see with hypoxia. Those are things that we'll continue to explore that I didn't talk about in this talk. So limitations. When these individuals are sitting there in this chair, it's not really clear how much of a stressor acute intermittent hypoxia is. When you're talking about an animal who can't breathe well after a spinal cord injury and you're giving it 5 minutes of hypoxia, that's a long time. So if I sat in that mask for about 2.5 minutes, I would start feeling it. We only did 60 to 90 seconds. All right. So the subjective responses were very limited until you get to those longer durations. So how much stress this is not really clear. And there are also other things we can investigate to stress the nervous system more, like hypercapnia, which is being explored in Gordon Mitchell's lab down in Florida now. So with hypoxia, there might be a potential benefit, but further assessment is needed to establish the efficacy and safety of intermittent hypoxia prior to doing high intensity. The work was funded by the Indiana Spinal Cord and Brain Injury Research Foundation with other contributions from NIH. So that's it in a nutshell. I took out some slides so I could get through it. I'm sorry, I did talk a little fast, a lot fast probably. Anybody have any questions?
George, maybe I'll start. So the summary overall is that there was benefit seen in certain outcomes, but not in all. So the ones that maybe people are most familiar with, like um, the 6 meter walk test, um, that one
Not significant.
was not
Yep.
significant. Um, And I think one of the things that comes up is, which outcomes should be the ones people should pay attention to for changing clinical practice. And I wondered, what you thought of that because there's so many different ones to
Right.
look at.
So I would lean heavily on the core outcomes of that were recommended by the clinical practice guidelines in 2018. So if you're doing a quick core set, the main ones that we tend to get are 10-meter walk speed, and typically fastest walking speed is better than self-selected because some people just kind of mosey and take their time. So fastest speed over the 10 meters. 6-minute walk is also recommended because some people cannot maintain that speed for an extended period. So those two for sure. And then there's 4 other recommendations. One of them is a Berg, one of them sit to stand, which we do. But I would all of our studies, we do both the 10 meter and the 6-minute. The peak treadmill speed is there because people are deconditioned. We also get oxygen consumption measures during the graded exercise test. That's not clinically as feasible or relevant. So that was just one thing that we consistently do. But I think that you kind of need to do both. I think the reason why they got better at 6-minute is because they went through the high intensity and they were more conditioned and they could maintain that distance for a longer period, which is why you probably didn't see differences between the groups. But you did see consistent differences in the other measures, fastest speeds and treadmill speeds. So if you don't know that, where's the chat box? Okay. More JNPT 2018 core outcome measures, CPG. And that's just freely available online that you guys can get.
Yeah. Just because it may be trying to get everything positive, may not be realistic. I'm just trying to, it's the peer review community, out there that we work within for acceptance. And I don't know if the bar is too high that you have to hit on everything,
Well, yeah. Well, not always, right? Because I just ran a study that's trying to get published with spinal cord injury, high versus low intensity. And because of preliminary data, I said the fastest speed would have been better. And fastest speed wasn't better, but 6-minute, which wasn't better on the preliminary trial, was better in the larger trial. So I'm not sure how much it mitigates the outcomes. I don't know if you have to hit on everything. Um, a lot of these studies don't hit on everything. If you look
Right.
at all the high intensity training, the Mako data, Richard Mako from University of Maryland, he's since retired. He doesn't improve on fastest velocity, self-selected velocity ever. It's always 6-minute walk, and that's it.
So I have to ask, where are you going next, with all of this? Because it is really intriguing. We find remote ischemic preconditioning has potential benefits in so many other areas for stroke prevention and, as
Mm-hmm.
well as in the acute setting of an ambulance. It really does seem like there is a mechanism. Maybe it's not all serotonin, but
Yep.
maybe there's other things like you said, BDNF or muscles are releasing different factors. So
Yes.
just curious, it seems really promising to me, and I was just wondering, are you um, looking for new NIH funding to go to a bigger trial, or where are you going next?
So that was already applied for. I got a decent score. I mean, who knows if they're going to fund anything anymore from this administration. But I resubmitted, and we'll see what happens. You just got to keep on throwing it out there. Um, I will tell you that I did not think this would work. This was going to be, I don't think this is going to happen. And I was dead wrong. And that's okay. Because in 3 of the measures, it did actually happen. But I was certain it wasn't because of the high intensity I thought would probably give you as much as you need. But then I get worried about, are we stressing the system out enough? Like, or is it too much? And we're going to induce these kind of adverse events like the SVT in that patient. So looking at hypercapnic responses in addition to the hypoxia, then and I didn't talk about this in the talk, but there's all these drugs such as over-the-counter, not even medications, caffeine, ibuprofen, oh gosh, there was, sorry, another prednisone. These drugs can influence the hypoxic response. And so caffeine tends to boost the hypoxic response. Ibuprofen doesn't seem to do much. Prednisone seems to actually limit the responses, or sorry, improve the responses. So these kind of anti-inflammatory agents will boost responses, and caffeine works through another mechanism. So trying to control for all that is something that we're going to post hoc evaluate. And then just, still look at safety because that SVT had not been seen, and kind of makes sense based on the hypoxia, the sleep apnea literature. But yeah, definitely going for more funding. If it doesn't work, then that's okay because we've learned something. And then maybe we go back to the spinal cord injured individuals and say, okay, do I really need the hypoxia or can I just push them hard?
Got it. I'm just curious, what are the reviewers having issues with? What kinds of things are coming up?
Oh gosh, it did pretty well. It was 21%. So
Oh,
not bad for a first round, right?
yeah.
So they were pretty minor, and hence I need to flip it quickly and get it back in there.
Okay.
But
Well,
we'll see, right? With Trump in the office, who knows? Any thoughts on adding another outcome measure for motor recovery? So, do you want to? Yeah, the Fugelmeyer. So, Sean, you can talk about this, or anyone who wants to chime in. The Fugelmeyer is pretty hard to change, and people have talked about this proportional recovery of the 70% rule, and regardless of the studies and their potential flaws, there is a consistent trajectory of Fugelmeyer that is really difficult to actually alter. So having that as a primary outcome measure may not give you any bang for your buck. And plus, as a physical therapist, some people are just not going to bend their knee. Some people are not going to lift their ankle. Some people are going to have hyperexcitable reflexes all their lives. But I can make them walk better. And isn't that more important? I think the argument would be, yeah, walking's more related to all these other things related to societal, uh, getting back into your regular uh, lifestyle, things that you do in the real world, going back to employment, interacting with family, friends. Walking is a primary determinant.
You have other impairment scales, from the motor side, for the lower extremities.
Yeah,
Um,
go ahead.
No, I was just going to say, because I mean, fecal MAR for the lower extremity is not as done. I feel like, compared to the upper extremity.
Yeah. We in the next version we have strength measures, just general impairment, peak maximal volitional contractions. There is a new study that said that hypoxia in like it was 5 people with stroke improved strength in the paretic but not the non-paretic arm with hypoxia. That was published after our study was published. And I didn't put that finding in there because we did this first. So were the findings translated to function daily walking activities? No, there were no differences between groups. There were improvements across the group, but there are no differences. It's really hard to change what people do in the real world unless you're actually trying to actively change what they do in the real world. Meaning, if you want them to walk more in the community, you've got to give them some kind of scheduled some regimen to do something more in the community. And that was Darcy Reisman's work that I participated in the ProWalks trial. Really hard with just doing high intensity training. I'm just going to put 2022, that is a community mobility. The group that did the high intensity plus all the variable stuff that I talked about, overground, treadmill, stairs, that seems to improve the walking training in the community to a better extent. Do you envision a possibility of integrating acute intermittent hypoxia into a typical stroke rehab program in the future? Not yet. So I think people just jumped the gun, and with the adverse event of SVT, with that drop off in the first population due to high intensity, and then did the hypoxia second, those things are things that we need to kind of explore to see if this is a real thing. I'm not sure it is, which is why I was skeptical to go in. And so that's why we kind of need more money before we implement these things, because we as a society and in rehab society are way too interested in implementing far before there's enough data there. Like spinal stimulation, what are we doing there? Like, let's get some real data on this first. And I mean transcutaneous. Epidural seems to be pretty cool, but invasive as heck.
That's why we're big fans of yours, because you're a trialist. You're really trying to prove yes or no, with rigorous studies. And we just we need a lot. We just need a lot more of that, I think, in rehab medicine.
It is just well, I mean, you've done this, I'm sure, but like one data point is months. You're like, okay, these are a grind, but I think they're critical because some of these 1-day studies that we do doesn't really show much. Like what you show for 1 day, does it last over extended period? But yeah, I like doing these things too, because worst day, you help someone walk better.
Yeah, I just think we need to. I often feel like I've talked with people like Sandra about the fact that we should all collectively come together and figure out how to find more funding sources.
Right.
Because you mentioned the difficulties with NIH, but even before these difficulties, it really feels like the amount of budget that's associated or given to NCMRR is very low. And StrokeNet is also very low when it comes to rehab studies.
Well, luckily they won't fund animal studies anymore at NIH, so that can only help us. It's a joke. So there's a question there. Any thoughts on excluding people with arrhythmias? No, because people with stroke always present with arrhythmias. So you've got to kind of like, you don't want it too narrow of an exclusion criteria or inclusion criteria because you want it more generalizable. And if it's more generalizable, then if you have a positive finding, then you could actually think about implementing. But until you do that and see a larger population, who does this really work for? Are the adverse events really there? We shouldn't be implementing anything. So I want to include those people because people with stroke have every type of comorbidity and every type of arrhythmia. And that's your general stroke population that we want to address the walking deficits.
That's case reportable, what you found there, if it was related, and you said it wasn't. So I mean,
it is. Well, we put it in the paper. We definitely talked about it in the paper. Like this could be a problem.
Yeah.
Any other questions, guys?
This is great. I really thank you so much, George, for your time. I mean, it's just it's a new educational venue that we've created for Texas, and so really appreciate it.
there's another question, Sean, before we go. Working through the serotonergic system, these outcomes be confounded by a positive effect on baseline depression. Was this considered? There were no differences in PHQ-9 scores to start, but it's in the paper, those who were on antidepressive medications, which almost all of them were serotonin based, tended to have worse outcomes with the training with hypoxia. And so the idea there is maybe there's this depression of serotonergic pathways with chronic SSRI ingestion, which is seen in Cholet's data back in France in 2009.
Flame study. Yeah.
What? The flame
The
study.
flame studies. Yeah.
Yeah. So those associated studies before the big flame study was done, that could contribute. The downregulation of serotonin receptors could contribute to less responses with hypoxia, theoretically. Again, N of 28. How long was the washout period? 1 month. So in the new trial, we talked about maybe doing 3 months, but now you're talking, 5 to 6 months of a single data point. So these studies become harder to do. The more you put guardrails on the system, make it more rigorous. All right. I'm sure you guys all have busy days. I know I have crap in the lab I have to do. If you have any questions, my email, I'm just going to type it in there. Do not hesitate to contact me. More than happy to answer questions. But thanks for inviting me. Appreciate it.
Thank you again. Thank you, George.
Yeah, no problem.
Wonderful work.
All right.
Thank you.
All right, guys. Talk to you later. Bye-bye.